Hi, everybody. Thank you again to Hills and K-State for having me, and thanks to all of you for listening to me. All right, so this hour, we're going to talk about gastrointestinal emergencies. Pretty similar to the first hour. I don't really have a lot of time to talk about a lot of specifics, so this is going to be general approach to the animal who comes in with a GI emergency. Our learning objectives is we'll kind of talk about stabilization of that patient with GI disease. We'll talk about a fluid plan, how we come up with the fluid plan for animals with GI disease, and then we'll talk about analgesia, and then a couple of things here and there. All right, so I want to introduce you all to Jojo, and we'll see if technology works for me today. But Jojo is a 2-year-old female spayed Shih Tzu who presented for diarrhea. She'd been having diarrhea for 48 hours. Her owners didn't really pay very much attention or thought she would be fine, which is the case in a lot of situations until she started vomiting. So she had a couple episodes of vomiting for about 24 hours, and then she became lethargic and she stopped eating. So they got really concerned and they decided to bring her over to you to be seen. And on their way to the hospital, Jojo developed some hematochezia. So on her physical exam when she arrived at the hospital, she had a heart rate of 180, respiratory rate was 30, her temperature was 99.4. Again, we talked about that distal pulse. It felt fair on the exam. You could kind of feel it, but it wasn't the strongest. She was pale pink on her mucous membranes. Her capillary refill time was less than 2 seconds, and her mentation was quiet. All right, so I have just two questions in this presentation. We're going to see if Pull Everywhere would work. So if you all will just join by sending my last name, it's ODUNAYO. Just text it to 22333, and you should get something back. Do you work? ODUNAYO. Yay. All right. So, and you're just going to either say true or false or A or B for whether you think Jojo is stable. All right. So most people said she is not, which I completely agree with. So she is not stable, and that is based on elevated heart rate of 180, having fair distal pulses. Again, her blood pressure probably ended up being maybe about 80 or 90, so borderline low, and then having pale pink mucous membranes. All of that point to poor perfusion or poor circulation, which we think of in animals who were like maybe hit by a car or having something traumatic happen, but it is certainly really common in animals with gastrointestinal disease. So she had evidence of shock. One of the things I did with this example is just to highlight that our patients do not always have to have every single sign. So she had a normal capillary refill time. Sometimes the pulse pressure might feel normal. Sometimes the CRT might be normal. They don't necessarily have to have every single abnormality. But I think one of the most common things we'll see would be that change in the heart rate in dogs and cats. So she had evidence of shock, which we just talked about. Very classically with GI disease, we will see hypovolemic shock, but we will also see distributive shock, maldistributive shock. This is what happens when, again, your blood vessels, instead of being nice and constricted, they get vasodilated because of cytokines, so that animal is unable to vasoconstrict and mount an adequate blood pressure. And this is the instance where we would usually consider giving drugs like dopamine or norepinephrine. It's usually after we have treated that animal with fluids and they don't respond, then our next step will be this animal could have a degree of vasodilatory shock. So this might be a situation to see if that dog or cat will respond to vasopressors. So these are just common diseases where we'll see animals present with evidence of shock. Again, sometimes we don't really pay attention to it. Dogs with parvo, they can come in, and we'll kind of talk about dehydration in a second. They can come in with signs of dehydration, and I think that's far more common in animals with gastrointestinal disease, but sometimes they do come in with signs of poor perfusion or shock. Again, pretty similar to what we talked about in the last hour, our goal would be to restore oxygen delivery. When we treat animals with shock, that is called resuscitation. So when we come up with the fluid plan to treat shock, we're resuscitating or reviving that patient. It's the same term we use when we're trying to revive neonates after a C-section or a patient who has died. We're doing CPR, we're doing resuscitation. It's the same thing with shock. It just places an emphasis on this patient is actively dying because of poor oxygen delivery, and we want to restore blood flow or oxygen delivery to the body. So we're going to give large volumes of fluids, which we talked about just a few minutes ago, and then use pressors if they do not respond to fluids. So what I did was I created this chart just as a quick cheat sheet or summary for how to treat shock. One of the things that I would say is there's really no clear evidence for what fluid is better than the other. So should I start off with an isotonic crystalloid like Namasol R or LRS, or should I be using a colloid like Hetastat, which, other than the controversies associated with colloids or synthetic colloids, there's just no evidence in human medicine, and definitely nothing in veterinary medicine that has shown one fluid type is superior over the others for treating shock. So I usually start off, I actually don't really use a lot of synthetic colloids anymore, although there's actually not strong evidence in dogs and cats that we see some of the adverse effects that has been demonstrated in people. So I usually start off with an isotonic crystalloid. Again, the goal is we're given roughly about 20 to 25% of the shock dose over 15 to 20 minutes. In animals who may have ongoing bleeding or blood loss, you may have to give a red cell transfusion really fast. So historically, when we do blood transfusions, we usually do it over 4 hours. But if that patient is in shock or that patient is dying, again, your goal would be to give that patient that hemoglobin as quickly as possible. So we would also administer that as a bolus. Usually I try to get my red cell in over 15 to 20 minutes. Some patients might be in shock because the total protein is just really low. So I think a good example, doesn't happen in all cases, but dogs with parvo, sometimes they come in and the albumin is like less than 1. And because the albumin concentration is low, they cannot maintain an adequate intravascular volume. We know albumin is what helps keep fluid in the intravascular space. So in some instances, if your albumin is low, it doesn't really matter how much crystalloids you give, that animal is not going to respond until you replace the albumin, which the most effective way is to actually give albumin, but you may consider plasma if you don't have that available. And then we talked about vasopressors. I don't have specific doses up here because there's a wide variety of them. It's easy to find, and certainly depending on how your practice is set up, if you have an animal that's just not really responded to fluids, the blood pressure is still low, heart rate still high, you may consider transferring them somewhere so that they can get started on vasopressors. How do we know that our patient has responded? I've kind of said this a couple times, but going back to your endpoints of resuscitation. So as the patient looking better, many times the augmentation will improve, the heart rate will come down, the blood pressure will come up, the CRT will be better. So going back to Jojo responded really well too. She just got 1 bolus of isotonic crystalloids. And then we performed a full physical exam that showed she was roughly about 6% dehydrated. She had evidence of hematochezia based on her rectal exam. She was a little bit nauseous when her abdomen was palpated, and the rest of her physical exam was otherwise normal. How many people have had cases like Jojo come in to your practice? Yeah, I feel like this is a bread and butter of veterinary medicine. We see dogs with vomiting and hematochezia, at least in the ER, I would say all the time. It's probably about 70% of what we see, and that's probably true for those of you in general practice too. So once we have this dog, so again, we've identified she's in shock, we've stabilized her. The next question is, what's the underlying cause? Why is she sick? And like I tell my clients, I usually like to tell them up front that there's probably over 100 different reasons why a dog will vomit. The reason I tell them that is to just try to get them thinking of the fact that, first of all, we may not find an underlying cause, but secondly, sometimes we need to do more advanced diagnostics. So we kind of think about my differentials. I always like a problem-based approach to any case that I see. I identify the problem, I come up with some of our common differentials, which leads me to my diagnostic plan. So on the slide, we have a fair list of things that I would consider like basic diagnostics for an animal who comes in with vomiting and diarrhea. None of this is like very shocking to any of you. So we're going to do standard blood work. I always do a point of care ultrasound because, again, sometimes I've been able to identify free fluid. Oh, this animal has septic peritonitis. And you can make that diagnosis within like 10 minutes of the animal walking into your practice so that you can start treatment really quickly. In academia, we're actually, well, I guess I would say the institutions have been, I'm sure Kansas State is way better, but we're really bad about doing phacals, which general practitioners are way better than we are. We're more likely to proactively treat. So regardless of whether we did a fecal or not, we'll deworm them, which is not unreasonable because we know fecal tests are not necessarily like 100% sensitive. But I also think in light of like hookworms, where we know that there is now hookworms that are resistant to traditional antiemetic medications. I think it's reasonable for us to start thinking about, well, maybe we should actually be testing these patients instead of preemptively or prophylactically treating them. Probably depending on the signement and abdominal radiographs, depending on the case, sometimes we will do a urine culture and an abdominal ultrasound. I'm going to come back to this test in just a minute, but these are going to be the standard tests we would consider. How do I know? I mean, am I going to do every single test in every single patient who comes in with vomiting and diarrhea? The answer is no, probably unlikely. I think we would all use a sense of judgment and say, this animal looks really sick. I think this is an animal where I really want to do everything. I want to do some blood work. I want to get some x-rays. This dog that's wagging its tail, I may potentially just send it home and try supportive care. But we'll come back and kind of talk about this when we talk about a recent study. And this just highlights some of the additional tests that could be considered. Usually, we wouldn't do a lot of this acutely. It would be in that animal that has failed medical management. Maybe the dog's been in the hospital for 2 or 3 days, not really improving. Then I want to think about, well, do I want to do something else? Should I get a baseline cortisol, possibly? Do I want to do a fecal culture or potentially endoscopy? So these are tests that we're less likely to do in the acute emergent phase. All right, I got really excited about the study. This was actually done in 2023, so recently published. And what they did was, which kind of takes me back to that question, I had a list of diagnostics that one may consider in an animal with acute vomiting. And what they did was they looked at 99 dogs who presented to essentially their emergency hospital through internal medicine. So those dogs came in for vomiting, and some of them had diarrhea. And for all 99 dogs, they did CBC chemistry, UA, they did a point of care ultrasound, they did a full abdominal ultrasound, and then they did a CPL. And what they wanted to find out is, what is the utility of this test? Like, what test is more likely to give me an answer in a vomiting dog? We're going to go over the results in a minute, but what I would say to kind of keep in mind is they only looked at 99 dogs, which certainly that is a really low number based on their results. When you kind of go back and do an ad hoc power analysis, they really needed about 3,000 dogs to be able to say that, hey, this test is more significant or more likely to give you an answer. It's a really small number, especially based on the fact that dogs who come in for vomiting and diarrhea make up probably about, again, 60% of my practice. So it's a small number of dogs, but they concluded that if the animal comes in and the animal looks clinically stable, it's reasonable to kind of do minimal. You don't really have to do a lot of this diagnostic test. But if the dog has like an altered mentation, the dog has clinical signs other than diarrhea, like anorexia, then it is reasonable to move on and do those tests. It seems like probably pretty similar to what a lot of you do. This is a table from their results, and what's outlined in this table is they have the different tests. So moving from blood examination all the way to the SNAP CPL. And then they had a utility score ranging from 1 to 5. So what a score of 1 means is when they ran that test, they were able to obtain a diagnosis in that patient. They could say, yeah, this dog has pancreatitis because I ran a CPR. That dog got a score of, that test got a score of 1. And then it went all the way down to 5. So a score of 4 would mean that the test provided information that did not really affect, it didn't really change the diagnosis, with a score of 5 being that the test actually gave conflicting information that did not support the diagnosis or potentially may have hindered the diagnosis. So ideally what we want is a score of 1 to 2, which means the test was helpful, and then less likely a score of 4 to 5. And what I thought was really interesting was the CPL actually had the highest number of number 1 scores. So they were more likely to get a positive test for pancreatitis when that test was run and dogs who came in with vomiting. Really interesting was when you look at radiographs, they only had 3 dogs that radiographs were helpful to give them a diagnosis that only had a score of 3. And then if we look all the way down to looking at a score of 4, so again, that test did not really make a difference. Not surprising, the urinalysis had a really high score, but also x-rays had a really high score. What is my take home for this result? I would say that if you look at animals who had diagnosis based on x-rays and blood work, there's not very many of them. Like for blood work, it was just one. There was just one dog that the blood work was helpful in making a diagnosis. If that were my dog, I would really want to know that my dog had evidence of liver failure or acute kidney injury, meaning that even though it's not going to be the most helpful test based on 99 dogs that were presented in the study, I think it's still reasonable to give the clients options is what my take home is. So, and this doesn't really change what I do is when I go into a room, I saw a 1-year-old dog this past week with vomiting. I tell the clients that I don't think that blood work is going to show us anything, but I'm not going to be able to tell you that confidently unless I look. So this is how much it is. It's completely up to you if you want to proceed. I give them an opportunity to say no. I explain what I'm looking for. I'm assessing his kidney values and liver values. I don't expect that to be abnormal in a 1-year-old dog, but he could have gotten into something. This could be a toxicity. He could have some sort of congenital underlying disease that we're not aware of. And I give the clients an opportunity to decline the test. If I feel really strongly in the same case, this is a 1-year-old dog, I'm going to be worried about a foreign body. I think if we had to pick tests, I will prioritize taking x-rays and ultimately just let them make their decision. All right, so moving on, since the CPL happened to be the test in that study that generated the highest number of positive results, I just wanted us to go over that test specifically. So we know that the CPL is really specific. It comes from the pancreatic acinar cells. And in dogs, only about 1% of it, dogs and cats, only about 1% of it actually makes its way out into circulation. So usually it's really specific. It stays in the pancreas unless you have pancreatic inflammation, either from pancreatitis or potentially things like a pancreatic mass. So what we know in dogs about the sensitivity and the specificity of a CPL is it's anywhere from 74 to 100% sensitive and only about 59 to 78% specific. What does that mean for me as a practitioner? Is when I do a SNAP CPL, it's helpful to rule out pancreatitis. If I get a negative test, I am very confident in that result that that animal probably doesn't have pancreatitis. If I get a positive test result, then it could be pancreatitis. It probably is pancreatitis, but it could be a wide variety of other things. So diseases that have been shown to lead to a positive CPL in dogs include parvo, animals with kidney disease, which I actually tend to see that quite a lot, even dogs with gastric dilatation and volvulus. So I see sometimes, the dogs go in, the veterinarian does a SNAP CPL, it comes up positive. They don't get any other diagnostics. They don't get blood work. They continue to treat the dog for pancreatitis. The dog doesn't improve. And I don't think think that's wrong, but I guess what I would say is, if that dog's been in your hospital for 2 days and is not doing better, then there's probably a chance that there's something else going on. So I would encourage additional diagnostics and investigation. So in most dogs who come in with acute vomiting and diarrhea, I would say many times we don't really find a definitive diagnosis. They usually end up with the diagnosis of acute gastroenteritis, which is just the inflammation of the GI tract. It has really non-specific clinical signs and signalement. Really common in dogs, less likely to happen in cats. I think cats just tend to be like non-discriminate or more discriminate compared to dogs when it comes to eating things. So we're less likely to see this in cats, but this is a really common diagnosis in dogs. The great thing about acute gastroenteritis is it's self-limiting. It usually resolves in a couple days with supportive care. Pretty similar to acute hemorrhagic diarrhea syndrome. So this is what I grew up calling HGE, hemorrhagic gastroenteritis. I think a few years ago, a study was done looking at dogs with HGE, and they identified that there was actually no lesions in the stomach. These animals usually just had lesions associated with the intestines, which essentially nullifies the gastroenteritis part because they don't have gastric disease. So that's kind of where the new name came from, acute hemorrhagic diarrhea syndrome. It's usually characterized by large volumes of diarrhea. Usually those dogs will come in with the high PCV and low normal toe protein. It's almost pretty classic. Small breed dogs are generally predisposed, and usually there is no specific etiology identified. Some people have tried to implicate Clostridium as a potential cause of AHDS in dogs, but we know that it is completely normal to find Clostridium even in like normal dogs, so we don't really know if that actually is the reason dogs develop AHDS. A small population of dogs with AHDS will also develop sepsis. We'll kind of talk about this in the treatment. But the reason this happens is bacterial translocation. So you have movement of bacteria from the GI tract into the bloodstream, and that usually causes immunosuppression, neutropenia, and those animals may come in and present with sepsis. So we'll kind of talk about how we manage acute gastroenteritis or acute hemorrhagic diarrhea syndrome. So the cornerstone will be fluid therapy for animals in shock. We just kind of talked about that. We're not going to rehearse it, but I wanted us to spend a few minutes talking about treating dehydration in dogs and cats. And what I wanted to emphasize is, so usually what I do with fluid therapy is if I want to prescribe fluids, I do it the same way I do any other drugs. I use a dose. So I identify, does this animal have shock? If they do, that's going to be more urgent. I'm going to treat that first. Once I've treated shock, or if shock is absent, which I would say with GI disease, most animals do not present in shock. So most of your patients are going to be hemodynamically stable, which means you don't have to give them a fluid bolus and they're not showing any signs of shock, but they may come in dehydrated. So our next plan would be to rehydrate them. And we also want to make sure we're intentional about coming up with a fluid plan for rehydrating those patients. So instead of just arbitrarily saying, I'm going to put you on 2 or 3 times maintenance, we'll talk about why that should be discouraged. We're actually going to sit down and come up with an actual fluid rate based on how dehydrated the patient is. And it's really easy to do. It takes less than about 2 minutes. So the first step is we're going to try to estimate how dehydrated that patient is, and that's going to be based on our physical exam. This is going to be a little bit subjective because I am going to probably feel an animal is maybe 6% dehydrated, and if you looked at that dog, you might say, oh, I think it's 5 or 7%. I always tell my students, you're not wrong. This is ultimately just something you do, and you come up with a plan for how you assess the patient's hydration. So if there's going to be differences in your practice, it doesn't mean that one person's wrong or one person's better. It just means that we just have slightly different way of assessing our patients, which is completely fine. So based on our physical exam finding, we're going to assign a level of dehydration. Animals who are less than 5% dehydrated are those animals who come in with the history of vomiting, not eating. Maybe that animal hasn't really eaten or drank any water for 2 days, and then you do a physical exam and that animal is completely normal. You don't see any signs of dehydration, I would say that animal is subclinically dehydrated, so less than 5%. And then it goes all the way to greater than 12%, where we will start to see signs of shock in that patient. And what that means is because that animal with dehydration, they've lost a lot of fluid from the interstitial space. We now have a situation where fluid is leaving the blood vessel, the intravascular space, to replace what's been lost in the interstitium. And that's going to lead to shock in that patient. It's really rare that we see animals come in shock because of severe dehydration. I would actually say that most of our clinical patients are going to be between 5 and 7. Maybe a really dehydrated animal would be like 9% dehydrated. But if you think back at the last dehydrated patient you saw, that patient probably didn't have sunken eyes secondary to their dehydration. It happens, but it's just really uncommon. So most of our dogs and cats are usually going to be, again, either subclinically dehydrated or generally between like 5 to 7, maybe potentially up to 9% dehydrated if they had evidence of sunken eyes and a really bad skin turgor. The other thing I just wanted to emphasize too here is the clinical signs of dehydration in this table is very different from hypervolemia. So when we talked about shock and hypervolemia, we were looking at things like the heart rate, the mucous membrane color, the capillary refill time, the pulse quality. All of those indicate a fluid deficit in the intravascular space in the blood vessel. Very different from dehydration, where we're talking about a fluid deficit in the interstitium. So those classic signs would be dry mucous membrane, skin turgor, sunken eyes, maybe a doughy abdomen where the abdomen feels like bread dough. Usually that can be identified easier in puppies and kittens. So very different, but also really important to keep in mind when you're assessing your patients because they tell you completely different things. So if you think that the animal has a prolonged capillary refill time, it means that patient is likely in shock and that patient needs to be treated with the fluid bolus because that's life-threatening. Dehydration is rarely life-threatening. Again, that patient has to be greater than 12%, which we just talked about, just doesn't really happen often. So with dehydration, the good news is we can take our time. We don't have to give large volumes of fluids. We don't have to give it really quickly because that animal is not dying from its dehydration. So specifically for Jojo, what we did was she was 6% dehydrated on her physical exam. She's 5 kilograms. So we're going to calculate her fluid deficit, which is how much fluid she's lost before she came to your practice. We knew that she had been having diarrhea for 2 days, vomiting for a day. So we're going to estimate that by, again, getting the percentage dehydration, multiplying it by her body weight in kilograms. And that's going to give you your deficit in liters. So at 6% dehydration, 0.06 multiplied by 5 will give you a fluid deficit of 300 mils. So that is, again, how much fluid she lost before you actually saw her and did your physical exam. The next question is, how quickly do I want to give this back to her? Again, because she's dehydrated, this does not have to be given in a rush or hurry. We don't have to do a fluid bolus. I personally like to rehydrate my patients over 8 to 24 hours. I usually pick 12. It's easier. Sometimes if I want them rehydrated faster, I'll do 8 to 10. The only exception would be cats, because again, cats can have profound cardiac disease and not have a murmur. I always tend to be conservative with fluid therapy in kitty cats, so I do 12 to 24 hours if they have a murmur, or if it's a dog with a heart murmur, I'll do 12 to 24 hours in that patient. So in Jojo, we decided to rehydrate her over 12 hours, which ended up being 25 mils an hour. So if I gave her 25 mils an hour for the next 12 hours, she would have had 300 mils, which would replace her deficit from the interstitial space. Now, the only other thing we need to consider is she's going to be in your hospital for at least 12 hours, maybe longer. And during that time, she's going to have a maintenance requirement where she's probably still not eating or drinking because she still feels sick. So we need to take that into account and calculate her maintenance rate, which we usually will use. There's lots of different formulas, but I usually would use 60 mils per kg per day. Some people go as low as 45 in large dogs or cats. So her maintenance requirement will be about 12.5 mils an hour. This is just the volume of fluid her cells need to, again, kind of keep up with her basic metabolic requirements until she's back up to eating and drinking by herself. So that gives us a total fluid rate of roughly about 38 mils an hour for the first 12 hours. So after 12 hours, she should be rehydrated. So you can stop that 25 mils an hour and just have her at roughly at 12.5 mils an hour for her maintenance. This is very different from if I had just decided to put her in 2 times maintenance. So if I had done 2 times maintenance for her, it would be 25 mils an hour, which means at this rate, it would take much longer to get her rehydrated. The question is, why is that a big deal? I just told you that rehydration or dehydration is not an emergency. So what if it takes her 3 days to be rehydrated instead of 12 hours? It's not a big deal. I think what it comes down to is in some cases, especially with dogs who have non-specific gastroenteritis, they don't feel better. They don't start to eat. They're still lethargic. It's just like us until they're rehydrated. So what that means is you have this dog in your practice for 2 or 3 days and you're like, well, it's still not eating. Am I missing something? Do I need to go get an ultrasound? And the reason the animal may not be eating is just because it's still dehydrated. So I think it's helpful, not only because fluids are a drug, to be intentional and actually have a plan, but also it makes the animals feel better faster once they're rehydrated, and then they can start eating and you can send them home. So that's our number one therapeutic intervention will be fluid therapy. The other will be antiemetics, which I think we're all pretty good at doing this. We would give them something for nausea. I usually will do it for 1 to 3 days instead of just having them on it indefinitely. It certainly makes them feel better. They're less likely to have continued vomiting, which will lead to esophagitis and aspiration pneumonia. But it also allows you to provide enteral nutrition earlier, either because the dog's more likely to eat, or you're going to place a feeding tube, which we'll talk about in a minute. These are our most common antiemetics. Again, having had the pleasure of practicing pre-Cerenia, I still think it's a magic drug. I remember many years having dogs with parvo, and we would give them ondansetron and delasetron, and they'll still vomit through it. And then Cerenia came on the market, and now my house officers, they love delasetron and ondansetron, and they use it for everything, in addition to Cerenia. But I'm like, well, certainly some people argue that ondansetron is more of an anti-nausea medication and not necessarily for vomiting, but I honestly feel like Cerenia just keeps them more comfortable. So that's what I use. All right, the other thing will be gastroprotectants. And the big take home for that is that their routine use is not indicated. So this was something I did probably up until about 5 years ago. Anything that came in with vomiting, I put it on pantoprazole or omeprazole. And we know now, just based on not only evidence in people, but some evidence in veterinary patients, that it actually doesn't really make a difference when it comes to recovery. So this paper, which is open access, so you can also Google it and find it and read it. I think this was published in 2021. But this is the ACVIM consensus statement, where the authors of the paper did a literature review in people and in veterinary patients to look at how we should be using gastroprotectants. And their summary and their take home is you should strongly consider a gastroprotectant if the animal has evidence of an upper GI bleed. So that animal has a history of hematemesis, so you identify melena based on the history of your physical exam. The animal has evidence of reflux esophagitis. So one could consider it in that dog who's like vomited 10 or 15 times. Maybe there is evidence of some excess air in the esophagus, so the animal's like swallowing a lot and you feel like there's esophageal irritation. Dogs with polysystemic shunting, especially intrahepatic shunt, NSAID toxicity, and then as a prophylaxis for dogs with mast cell tumors. Otherwise, gastroprotectants are not really indicated for routine vomiting, so that dog with pancreatitis, AHDS, parvo, unless again there is a strong indication you think that this animal has esophagitis. It's not really going to make a difference in the outcome, and you could definitely save money. A bottle of pantoprazole in my practice is about $50, so that's $50 a day that I could actually use for something else. Another thing that's changing is also the use of antibiotics. And we actually just published this review paper, which is also open access, so you can pull it up. But in our review paper, we looked at 7 papers published in veterinary patients, and there's now 8 of them. So out of all the 8 papers looking at the use of metronidazole usually, but some of them looked at clavamox in dogs with diarrhea. And some of them just had plain old diarrhea, and some of them had hematochezia. There was just one study that suggested that the use of antibiotics led to a better outcome in those dogs. The other 7 either did not show a difference, or animals who were treated with placebo, so no intervention, no antibiotics, or treated with probiotics, actually had their diarrhea resolve faster than animals who had antibiotics. I remember when the first paper came out, it was looking at dogs with hematochezia, and they had given them clavamox. I think it was from the UK. And we had our next case, so we read the paper at Journal Club, and we're like, yep, we should be doing this now, because again, I had given metronidazole or antibiotics to dogs with diarrhea for probably maybe close to like 13 years before this paper came out, maybe a little bit longer. But I remember, I would never forget the case. It was a dog, it was like a collie who came in with hematochezia, and my resident asked me, he was like, all right, we have a fluid plan, we have antiemetics, are you sure I should not use antibiotics? And I said, yes, we're not using antibiotics. But on the inside, I was very, very nervous. I was like, oh my God, what if this dog dies? Because it was hematochezia, and sometimes those dogs get bacterial translocation. And the dog did fine, and I have done this now for probably about 5 years, and I don't even consider or think about it, because in my experience, they do about the same. They leave the hospital, their diarrhea is resolving, and again, based on the evidence we know that pretty much in most cases, they do not have any negative consequences, other than when you use antibiotics, unlike unlike gastric protectants, where we're just saving the client's money in general, although there is maybe some evidence that it might affect the dysbiosis index, just in terms of like the good bacteria in the GI. With antibiotics, we know that those dogs get dysbiosis. It takes them much longer for them to restore the normal balance of the good bacteria when we provide antibiotics. So this is just a quick flow chart we came up with in our review paper. And what we're recommending in dogs with acute diarrhea, which is defined as diarrhea that has been going on for less than 14 days, if it's not chronic, is to just try supportive care. So diet change, which is like the main course of our presentation today. So something that's highly digestible, maybe even considering adding some fiber to their diet, considering a fecal, maybe deworming them, although again, we should be better stewards of anti-helmetics, probiotics, and then giving them time. And if they don't get better, certainly some dogs do get antibiotic responsive diarrhea, so it's been going on for a while. You could absolutely consider it and consider potentially a walk-up for that animal. Maybe this is an animal that would end up having a chronic enteropathy. The only exception would be if that dog comes in and that dog has evidence of, immunosuppression, because sometimes they do. With AHDS, they get bacterial translocation. That animal is leukopenic, has a fever, hypertension, then you absolutely want to treat. And because I am not sure if we're going to get to parvo, I would say that's a good reason why we would treat dogs with parvo with antibiotics too, because they're often neutropenic when they come in. So we want to give them on something that would protect and help augment their compromised immune system. Otherwise, antibiotics are not routinely indicated. All right, analgesia would also be something to consider for GI disease. There's a ton of reason why these animals are painful. And like we talked about earlier, there is a negative correlation between pain and outcomes. So we already kind of emphasized opioids are going to be our best drugs, but I wanted to emphasize that for GI disease, our pure mu opioids are more likely to cause ileus. So the GI tract is not going to move. That animal is going to have a lot of gastric residual volumes. You might see that dog regurgitating more commonly than cats. Buprenorphine, a partial mu receptor agonist, is just less likely to cause that. So if I feel that the animal has mild to moderate pain, the animal is not severely painful, then buprenorphine is going to be my first choice for GI disease because it's less likely to cause stasis and ileus. If the animal is really painful, that dog has severe pancreatitis, then it is definitely going to be getting a pure mu agonist. Already kind of talked about this. All right, so ileus, other than drugs like opioids causing ileus, dogs with gastrointestinal disease can have ileus secondary to systemic inflammation, decreased blood flow to the intestines, recent abdominal surgery. I think it is important that we are able to identify this in our patients. And one of the most common things we'll see is those dogs, less commonly cats, will have recurrent regurgitation. And I think this is important to emphasize, especially when you're, interacting with your technical staff, or actually the other doctors in the hospital. Is it would be nice if somebody could either describe what the animal was doing or somebody was able to visualize it, because sometimes when you just keep finding, what appears to be vomitus in the cage, you're not really sure. I have this animal on like 2 antiemetics. Why is it still vomiting? There's a chance that it actually might be regurgitating secondary to ileus. So recurrent regurgitation is helpful to know. If you take radiographs, usually the stomach will be distended or the intestines. This is something else I love the point of care ultrasound for, because I put my probe on the stomach and you can see it's just distended and fluid filled, and there is no evidence of peristalsis. Nothing's moving. And then if that animal has a nasogastric tube, which we'll talk about in a minute, many times we'll get high gastric residual volume. So the tube is in the stomach. Every so often, usually we do it every 4 to 6 hours, we will pull back to see how much volume is in the stomach. And an animal who doesn't have ileus, that volume should be really minimal. With ileus, we're going to be seeing high gastric residual volumes. How do we treat ileus? Prokinetics generally, which usually we'll start with metoclopramide. It lasts longer when you give it either subcutaneously or as a constant rate infusion, IV, so 2 mg per kg per day. But the other drugs I've used, and sometimes depending on how severe the ileus is, sometimes I'm using all 3 of these at the same time. I really like the low dose erythromycin or azithromycin. So giving them at not the doses you would standardly use for antibiotics, but ultra low doses anywhere from 0.5 to 2 mg per kg. They have prokinetic effect at their doses. And then if you're able to get cisapride compounded, that can also be helpful depending on where the ileus is. Right. Other things other than utilizing prokinetics to treat ileus will be, we talked about minimizing opioids, so switching them to buprenorphine or potentially oral medications instead of a pure mu agonist. Increasing walk, so taking them outside and walking them if you're able to. And then lastly, nutrition. So by feeding the gut or feeding the GI tract, we're actually able to stimulate motility or movement of the gut. I wanted to just spend a minute talking about early nutrition and why that is important. So I think sometimes we're really good at pretty much everything I have just talked about. So we're really good at getting that patient in, getting that patient in IV fluids, doing some Serenia, maybe putting them on prokinetic. But I think sometimes we forget the value and the importance of early nutrition. So the guidelines for critical care nutrition, so for the patients you have hospitalized in your hospital, is if they have gone longer than 3 days without eating, and that's not 3 days in the hospital, that's 3 days based on their history. So for, a dog like Jojo, from day 1 when she stopped eating, even though she ends up in my hospital 4 days later after her clinical signs started, that will be a candidate for assisted feeding. That's going to be a dog we have to think about. I need to provide nutrition to not only stimulate motility of the GI tract, but also ensure that your enterocytes don't atrophy. When there's no nutrition, the cells in the intestines start to die off, which ultimately increases your risk for bacterial translocation and actually directly changes the prognosis for that animal. As in many things in human medicine, there is a ton of studies that ties prognosis for sick and critically ill patients with nutrition. The patients who are fed quicker and earlier do better than patients who are not. There's a couple of them in veterinary patients. This is one of them, and I have one at the end, which is actually in parvo. And the really exciting thing about parvo is there are now 2 studies that have looked at dogs with parvo. And the one thing in both of those studies that changed the outcome, one of them was the outpatient parvo study where the dogs were treated as outpatients, which is giving them nutrition. And in that outpatient, the first outpatient parvo study, what they did was they actually just gave them Nutricol, which is that pasty dextrose filled thing. It wasn't actually like, I don't want to say it's not real food, but because obviously glucose is like one of our basic macronutrients, but that's all they did. They just give them Nutricol because those patients were not in the hospital. And the dogs who got that did better than the dogs who did not. In this study, this was looking at dogs with pancreatitis. And this is when we used to encourage like rest in the GI tract with pancreatitis and not feeding them early. And what they did was they split the dogs into 2 groups. Half of them had enteral nutrition. They placed esophagostomy tubes and fed the GI tract, which is what we want to do. We always want to feed the GI tract. It's way better than parenteral nutrition. So for the other half, they gave them PPN IV. And what they found was the dogs who got enteral nutrition through an esophagostomy tube, they not only tolerated the feeding really well, but they had fewer instances of vomiting. So they didn't have more abdominal pain. They're less likely to vomit, which means you're more likely to get them out of your hospital much faster than if you did parenteral nutrition. So we don't really have a lot of time to talk about critical care nutrition, but it should be considered early in patients that are not voluntarily eating. Again, that magic number is 3 days because ultimately it decreases mortality, morbidity. It's well tolerated and easy to do. What can every practitioner do? So those patients may not be necessarily stable for an E-tube, and many times they don't actually need one because especially with acute gastroenteritis, they're going to be feeling better in 2 to 5 days. So I use a lot of nasogastric tubes, and I think this is absolutely not only easily placed and attainable in practice. There was a paper that came out just recently this month or maybe November showing that you can actually send those tubes home with your client. In that study, obviously you pick the right client, make sure they're trained, but in that study, those dogs did well. They placed the nasogastric tubes for different reasons. They couldn't really be hospitalized, and they were able to send them home and have the owners feed them. So really easy to place. You just get the tubes. Myla, I do not work for them or make any money. They haven't paid me a single dollar, but I love them. They're my favorite company because you can get almost anything. They sell these tubes. They're not very expensive. I think probably anywhere between $20 to $30 our cost, depending on the size. You place it by pre-measuring from the nose to the last rib. And that tells you how far you want to go. And the tubes can also end up in the esophagus instead of in the stomach. But I like it in the stomach because you can measure your gastric residual volumes. And at least one study has shown that there's no difference in complications if the tube ends up in the esophagus versus in the stomach. So you measure up to the last rib. Depending on how sick the patient is, the most I ever give is butorphanol, unless it's an animal who is really rowdy, got into a toxin, needs a tube for activated charcoal. I might give some dexmedetomidine, but for most sick patients, torb is sufficient. And you're going to just place it like you would place a tube in a horse. So eventually through the nasal meatus, and then you fit it all the way to your predetermined point based on your measurement, and then you secure it to the nose. Easily well tolerated. Certainly there's some complications. The scariest complication, which is really rare, so I don't really want anybody to think not to do this, and sometimes the tube ends up in the airway, and obviously you want to make sure that the tube is in the esophagus, the GI tract, before you start feeding. So common sense, we take an x-ray before we use it. I would say sometimes in my dogs with parvo, because they're in isolation and it's a pain to get them out and take x-rays, if I place an nasogastric tube and I have gotten 200 mils of gastric content, there's nowhere else that tube is but the stomach, because if that dog had that much volume in its lungs, then we have a different problem. So in those instances, I wouldn't take an x-ray, but otherwise you want to take an x-ray. The main take home for this x-ray is you want to identify the tube and make sure that it is not in the airway. And sometimes it can be tricky I wouldn't say tricky, but the blue circle shows that if you just looked at that segment, you would think that the tube is in the trachea because it's overlying the trachea. But if we look at the red circle, we can see that tube is dorsal to the larynx, which is where you want it to be. That's actually my preferred place to look when I get an x-ray, is I look at the larynx and ensure that it's dorsal to the larynx. It tells me it's in the esophagus. And then you watch and make sure the tube actually doesn't follow the main stem bronchi. The yellow circle can be a little deceptive. I've seen that happen before, where the tube was in the airway, was in the lung, but it just went all the way. It looked like it was over the stomach, and it wasn't in the stomach. It was in the airway. So always look ideally dorsal to the larynx, and then follow the tube all the way down. Make sure that, as you can see, I'm sorry, my pointer isn't working, but right past your blue circle, the tube is not in the airway anymore. So it's not falling through the main stem bronchi. You know that this is where you want it to be. So you want to get an x-ray and be done with it. All right. Oh, I'm done, right? Do I stop at 2? Yeah. Okay, so the other case I had, which I'm just going to take 2 minutes, was a dog with parvo. We're not going to get through that. And it was largely because I'm overambitious and I also talk too much. So I knew I was probably not going to be able to cover parvo. But the 2 main things I wanted to say is with that parvo snap test, sometimes you can get false negatives. I'm sure you've all probably seen that. So now having a positive test does not mean that animal doesn't have parvo. If it smells like parvo, that's a young dog, the animal is neutropenic, which happens fairly commonly, I would treat it as parvo. The second thing I also wanted to touch on, how many people have used the monoclonal antibody yet? Yeah, what do you think of it? Okay, so didn't really make much difference. We just got it. It was a Frenchie, so who knows? We just got it, so I am excited to use it. I just wanted to say, so the way that antibody works is it binds to the antigen, it binds to the parvovirus, it prevents it from going into the enterocytes or the bone marrow and destroying the enterocytes in the bone marrow. Where I think it's probably the most useful, so Elanco did that study where they got puppies, healthy puppies who had not been vaccinated. They infected them with parvo. They tested them every single day. As soon as they tested positive, they gave half of them the monoclonal antibodies, and the other half didn't get anything, didn't get treated. About 58% of the untreated group died because they got no treatment. 100% of the dogs who got the monoclonal antibody lived. I think where that antibody is going to be most helpful, because again, it prevents the antigen, the parvovirus, from getting into the cells, will be dogs who have minimal clinical signs. So best example would be that breeder or owner who has multiple young puppies in the house. One of them tests positive. The others is still playing. They're not sick, but they've been exposed. I think that would be a perfect situation to give it. I think once the animal has clinical signs and the enterocytes are all destroyed, the bone marrow is suppressed, I'm not sure. I mean, I wanted to, so I'm still kind of looking forward to see how it pans out. But pretty similar to the COVID antibodies, I'm not really sure it's going to make a huge difference when that puppy is already sick and in your hospital. So just something to think about, especially if it's a case where the client doesn't have a lot of money. I know it's about $200 a vial, is I would consider, until we have enough evidence, do I want to spend that money on this dog that's like really sick, or should I save that $200 and put in a feeding tube and do something else that would actually be really helpful? I'm sorry I went over, but thank you so much.